Assalamu alaikum. Today we are going to discuss two important subjects in pediatric nephrology. It is nephrotic and nephritic syndrome. Firstly, we are going to speak about nephrotic syndrome, mainly minimal change type. At the end of this lecture, you are going to learn the types of nephrotic syndrome, the clinical manifestation, and how can we reach diagnosis, what is the investigation that's required for making the diagnosis, and the treatment plan, lastly the complication. Nephrotic syndrome is a clinical manifestation of different glomerular diseases that are associated with heavy proteinuria, which is called nephrotic range proteinuria. The nephrotic range proteinuria is defined as proteinuria that is more than 3.5 gram per 24 hour, or a urine protein creatinine ratio of more than 2. Nephrotic syndrome affects about 1 to 3 per 100,000 child with age less than 16 years. The triad of a clinical finding that associated with nephrotic syndrome, it arises from large urinary loss of proteins. These will result in hypoalbuminemia, which is equal or less than 2.5 gram per deciliter, edema, and hyperlipidemia when the cholesterol is more than 200 milligram per deciliter. Clinical consequences of nephrotic syndrome. Firstly, edema. Edema is most commonly presenting symptom of children with nephrotic syndrome. Despite it is almost universally present, there is uncertainty about the exact mechanism of edema. The most commonly explained theory is that when the patient with nephrotic syndrome have heavy proteinuria, which is due to increased permeability of glomerular capillary wall, this will result in the fall in the plasma protein, corresponding decrease in the intravascular oncotic pressure. This will lead to leakage of plasma water into the interstitium, which will generate edema. As a result, reduced intravascular volume, there will be an increase in the secretion of vasopressin, arterial natriuretic peptide, which along with aldosterone, it will result in increase in the sodium and water retention by the tubule. Sodium and water retention therefore occur as consequences of intravascular volume depletion. However, this theory does not apply to all patients with nephrotic syndrome. Hyperlipidemia. There are several alterations in the lipid profile in children with nephrotic syndrome. For example, there will be increase in the cholesterol, triglyceride, low-density lipoprotein, and very low-density lipoprotein. The hyperlipidemia is thought to be due to an increase in the hepatic lipoprotein synthesis, which is stimulated by the presence of hypoalbuminemia. This combined with decreased lipid catabolism, which is due to urinary loss of lipoprotein lipase. Etiology of nephrotic syndrome. Most common causes of nephrotic syndrome in pediatric age group is idiopathic, or what's called a primary glomerular disease. For example, a minimal change disease, which is the most common type, or focal segmental glomerulosclerosis. We have also secondary nephrotic syndrome, which is occurred due to secondary to systemic diseases or syndromes. For example, malignancy like lymphoma, SLE, Henoch-Schönlein purpura. Also, we have congenital syndromes that result in a nephrotic syndrome. Clinical manifestation. The idiopathic nephrotic syndrome is more common in boys than in girls, with a ratio of 2 to 1. Most commonly appear between age of 2 to 6 years. It has been reported, however, as early as 6 months of age and throughout adulthood. Minimal change disease is the most common type in a young patient. Usually, it constitutes up to 90% of patients whose age less than 6 years. However, in an older patient, we should think of focal segmental glomerulosclerosis. Children with nephrotic syndrome can initially be presented with mild edema, which is initially noted around the eyes and in the lower extremities. Nephrotic syndrome can initially be misdiagnosed as an allergic disorder because of the periorbital swelling that decreases throughout the day. However, with the time, the edema will become generalized with the development of ascites, pleural effusion, and genital edema. Other feature that the patient may have is anorexia, irritability, abdominal pain, and diarrhea. Important feature of minimal change disease is that the absence of hypertension and gross hematuria, which is called the nephritic feature. The differential diagnosis of a child presented with generalized edema is acute or chronic glomerulonephritis, protein-losing enteropathy, protein malnutrition. Patient can have hepatic failure or congestive heart failure. In order to confirm our clinical diagnosis, we send the patient for general urine examination looking for proteinuria. Usually the patient have a nephrotic range proteinuria which is more than 40 mg per square meter per hour or more than 150 mg per kg per hour. We can also use a urinary protein creatinine ratio that depends on the first voiding at the morning sample, which shows that more than 2. We have to measure the serum albumin. Usually it's less than 2.5 gram per deciliter, and the patient have evidence of hyperlipidemia in which the cholesterol is more than 200 milligram per deciliter. The renal function tests and the complement are usually normal. Renal biopsy is not routinely indicated in patients with nephrotic syndrome if he fits the standard clinical picture of minimal change nephrotic syndrome. However, we should think of diagnosis other than minimal change nephrotic syndrome, and a biopsy should be performed if the child whose age less than 1 year or older than 8 years, if they have family history of renal diseases, or the patient have extra-renal findings such as arthritis, rash, anemia, if the patient have hypertension, pulmonary edema, acute or chronic renal insufficiency, the patient have a gross hematuria, or if the patient show resistance to the treatment with steroids. Treatment of nephrotic syndrome. Children with their first episode of nephrotic syndrome who have a mild to moderate edema may be managed as an outpatient. However, most families require short period of hospitalization in order to take a time for understanding of the illness and teaching how to monitor the disease and to know its aspects. The cornerstone of treatment of minimal change nephrotic syndrome is steroid. We usually start with prednisone orally 60 mg per square meter per day as single oral dose in the morning for about 4 to 6 weeks. Then the dose should be tapered to 40 mg per square meter every other day for at least 4 weeks. After that, we have to taper the steroid until we stop it. Approximately 90% of children will respond to steroid therapy. Response is defined as achievement of remission within the initial 4 weeks of corticosteroid therapy. Remission consists of urine protein creatinine ratio of less than 0.2 or less than 1 plus protein on urine dipstick for 3 consecutive days. while relapsing nephrotic syndrome is defined as a urine protein creatinine ratio of more than 2 or more than 3 pluses protein on urine dipstick testing for 3 consecutive days. Relapse usually in nephrotic syndrome is triggered by infection like upper respiratory tract infection or GIT infection, and it's usually treated in similar manner to the initial attack. Patient with mild to moderate edema can be treated as an outpatient with corticosteroid and with salt restriction in the diet, just no added salt. And we can add loop diuretics orally, however, caution should be made due to the risk of thromboembolism. In contrast, patients with severe edema need hospitalization plus corticosteroid. Those patients require fluid restriction in addition to the sodium restriction, especially if the patient is hyponatremic. IV diuretic like furosemide can be used. However, if all the above measure is ineffective, then we have to give albumin infusion, which is followed by loop diuretics. Alternative therapy to corticosteroid in patients with nephrotic syndrome. Patients who are frequently relapsers or they are steroid dependent or resistant, plus children who suffer from severe side effects of corticosteroid may be a good candidate for starting an alternative therapy to corticosteroid. These are cyclophosphamide, cyclosporine, mycophenolate, and levimazole. Complications of nephrotic syndrome. The major complication of nephrotic syndrome is infection. It is a common cause of death in those patients. The most common site of infection is spontaneous bacterial peritonitis, although sepsis, pneumonia, and other type of infection all can occur. Streptococcal pneumonia is the most common organism that's implicated in this infection. The second complication is a thromboembolism. Although it is an uncommon complication, however, it is a serious complication, and that's why an overaggressive diuresis should be avoided to prevent this complication. Hyperlipidemia in nephrotic syndrome can put the patient at risk of cardiovascular event. However, myocardial infarction is rare in children. Also, patients with nephrotic syndrome may suffer from side effects of long corticosteroid therapy, and also he may suffer from some psychological complications. As we said previously that up to 90% of nephrotic syndrome in pediatric are idiopathic nephrotic syndrome. However, about 10 to 20% of the patients may have secondary nephrotic syndrome, that is secondary to some other diseases. For example, the patient may have glomerular disease that may have a nephrotic component, for example, membranous nephropathy, membranoproliferative, also some infection and infestation like hepatitis B and C and malaria. Some drugs can cause nephrotic syndrome in patients, for example, non-steroidal anti-inflammatory drug and penicillamine. Also, oncological conditions like lymphoma and leukemia. Other syndromes that may be associated with nephrotic syndrome is Alport, Alagille syndrome, and alpha-1 antitrypsin deficiency. Congenital nephrotic syndrome. Congenital nephrotic syndrome is defined as nephrotic syndrome that occurred at birth or within the first 3 months of life. It may be classified as a primary or secondary to a number of etiology such as in utero infection and infantile systemic lupus erythematosus and mercury exposure. We have two types. Firstly, the Finnish type. The Finnish type nephrotic syndrome is the most common cause of congenital nephrotic syndrome. It's usually inherited as autosomal recessive. Those patients usually deliver with hydrops, large placenta, and they usually tend to have prematurity and respiratory distress. The patient usually suffers from persistent edema with progressive renal function deterioration and usually end with death by the age of 5 years. The option of treatment is aggressive nutrition, ACE inhibitor, and IV albumin, IVIG, and unilateral nephrectomy. As you can see, steroids have no role in the Finch type of nephrotic syndrome. In the second part of this lecture, we are going to discuss an important subject. It is acute post-streptococcal glomerulonephritis. Acute post-streptococcal glomerulonephritis is a classic example of acute nephritic syndrome. It is characterized by sudden onset of gross hematuria, edema, hypertension, and renal insufficiency. It is one of the most common glomerular causes of gross hematuria in children. It is a major cause of morbidity in group A beta hemolytic streptococci infection. Etiology of post-streptococcal glomerulonephritis. It's usually follow infection of the throat or skin by certain nephrogenic strain of group A beta hemolytic streptococci. Usually, it follows streptococcal pharyngitis during cold weather months and streptococci skin infection or pyoderma during warm weather months. Regarding pathology, glomeruli appear to be enlarged and it is bloodless and it will show diffuse mesangial cell proliferation. There will be polymorphonuclear leukocyte infiltration that is common in the glomeruli during the early stage of the disease. Patients with post-streptococcal glomerulonephritis most commonly seen at age of 5 to 12 years, and it is uncommonly seen before the age of 3. Typical patient will presented as acute nephritic syndrome, either 1 to 2 weeks following streptococcal pharyngitis or 3 to 6 weeks after pyoderma. The history of nonspecific infection may be absent because symptoms may be mild or have been resolved without patient receiving specific treatment or seeking medical care. The severity of kidney involvement vary from asymptomatic microscopic hematuria with normal renal function to gross hematuria and acute renal failure. Those patients at risk of developing encephalopathy and or heart failure secondary to hypertension or hypervolemia. Hypertensive encephalopathy must be considered in a patient who presented with blurred vision, severe headache, altered mental status, or a new seizure. The effect of acute hypertension not only depends on the severity of hypertension, but also on the absolute change in comparison to patient baseline blood pressure and the rate at which it will be rising. Respiratory distress, orthopnea, cough may be symptom of pulmonary edema and heart failure. The acute phase of the illness generally resolves within about 6 to 8 weeks. After that, the hypertension is usually normalized and the urinary protein excretion will be returned to normal. However, the patient may continue to have persistent microscopic hematuria for up to 1 to 2 years. Diagnosis. We usually start with examination of the urine. Urinalysis, it will demonstrate the presence of RBC, often in association with red blood cell cast, proteinuria, and polymorphonuclear leukocyte. Patients usually have a mild normochromic anemia, which may result from hemodilution and low-grade hemolysis. The serum C3 level is significantly reduced in more than 90% of the patient in the acute phase. However, it usually returns to normal 6 to 8 weeks after onset. C4 is most commonly normal in those patients. Confirmation of the diagnosis requires clear evidence of prior streptococcal infection. However, positive throat culture reports might support the diagnosis or might represent only a carrier state. So a rising antibody titer to streptococcal antigen, it will confirm a recent streptococcal infection. The anti-streptolysin O titer is commonly elevated after pharyngeal infection, but rarely increase after streptococcal skin infection. The best single antibody titer to document cutaneous streptococcal infection is anti-DNase B level. If available, a positive streptozyme screen. It will measure multiple antibody to different streptococcal antigen. It is a very important diagnostic tool. MRI of the brain is indicated in a patient with severe neurological symptom. It can demonstrate posterior reversible encephalopathy syndrome in the parieto-occipital area on T2 weighted imaging. Chest X-ray is indicated in those patients who demonstrate a sign of heart failure or respiratory distress, or if physical examination finding of a heart gallop, decreased breath sound, crepitation, or hypoxemia. An early systemic antibiotic therapy for streptococcal, throat, or skin infection, it can reduce the risk of glomerulonephritis. However, it does not eliminate the risk of this disease. Treatment of post-streptococcal glomerulonephritis. In contrast to the patient with nephrotic syndrome, who can be managed as an outpatient if he developing mild or moderate edema, all patients with post-streptococcal glomerulonephritis have to be hospitalized. The patient firstly should receive a systemic antibiotic therapy with 10 days course of penicillin, which is recommended to limit the separate of the nephrogenic organism for the contact. The major life-threatening complications during the first 2 weeks are acute renal insufficiency and acute hypertension. Treatment of acute renal insufficiency in a patient with post-streptococcal glomerulonephritis. We have firstly to start with fluid restriction to 400 cc per square meter per 24 hour, which means that it consists of insensible water loss plus urine output. If the patient is still anuria with evidence of volume overload, we can restrict the fluid further. If he is still anuric, then we go on for dialysis. We have also to manage other sequelae of acute renal failure like hyperkalemia, hypertension, and metabolic acidosis. During course of acute post-streptococcal glomerulonephritis, it is very important to recognize the presence of hyperkalemia, and we should take an early measures for treatment. An ECG is very important in those patients. The earliest ECG finding it will be peak T wave. This may be followed by widening of QRS complexes and ST segment depression. The patient on later stage may develop ventricular arrhythmia and even a cardiac arrest. The first action of treatment in a child with concerning elevation of a plasma potassium is to stop all the external sources of potassium, whether it's orally or intravenously. Firstly, we give a patient a K-exhalate. K-exhalate is an exchanging resin. It is given either rectally or orally. The sodium in the resin is exchanged for body potassium, and the potassium containing resin is then excreted from the body. If the potassium level is more than 6.5 milliequivalent per liter, then a life-threatening arrhythmia can occur. The treatment of hyperkalemia will be directed at two basic goals. Firstly is to stabilize the heart and prevent life-threatening arrhythmia. A second is to remove the potassium from the body. Firstly, we give the patient calcium gluconate in a dose of 1 cc per kg IV over 3 to 5 minutes. The calcium will stabilize the cell membrane of the heart and it will prevent arrhythmia. However, it does not lower the serum potassium level. Secondly, we give sodium bicarb. This will shift the potassium from the intravascular into the intracellular department. Also, we can give an insulin plus glucose infusion. A similar effect has been reported with acute administration of beta adrenergic agonist. However, if the patient does not respond to the above measure, then he may need a dialysis. The standard therapy to treatment of hypertension in post-streptococcal glomerulonephritis consists of sodium restriction, diuresis, usually with intravenous furosemide, and pharmacotherapy with calcium channel antagonist, vasodilator, and angiotensin converting enzyme inhibitors. A longer acting agents, just calcium channel blocker or beta blocker, may be helpful in maintaining a good blood pressure control. Children with severe and symptomatic hypertension may be treated with continuous infusion of nicardipine, sodium nitroprusside, labetalol, and ismilol. During the treatment, blood pressure should be checked at interval of 4 to 6 hours, and the patient with hypertensive encephalopathy or sign of pulmonary edema or diastolic blood pressure more than 95 is indicated. Prognosis. Complete recovery occurs in more than 95% of children with acute post-streptococcal glomerulonephritis. Recurrences are extremely rare. Mortality usually occurs in the acute stage, and it can be avoided by appropriate management of acute renal failure, heart failure, and hypertension. Infrequently, the acute phase is severe and it will lead to glomerulosclerosis and chronic renal failure in less than 2% of the children.